I'm a complex disease navigator and COPD program coordinator that specializes in COPD, CHF, and tobacco treatment. I have created 2 COPD management programs that have provided great results in reducing COPD readmissions, and I help to empower patients through self-awareness and management. Many patients who have COPD think that they can just take their inhalers and that means that they're properly managed. But as we know, it is way more than that, and COPD is not just a diagnosis, but a whole lifestyle. The information included in this presentation, I hope, helps to cultivate a different conversation with them. I know we're frequently in and out of patients' rooms, and I want to just help people to maybe make things a little bit different every time that they go in. My goal is to give you the information and statistics to help patients become more compliant with their treatment, to help identify when AVAPs or airway clearance devices at home would be beneficial as part of, to prevent readmissions and to increase the quality of life, and to help navigate through conversations of palliative care and hospice with patients, families, and even that resistant provider. So some of the items that we're going to go over, we're also going to go over a lot more, but how does NIV play a role in COPD management? How does air quality affect COPD? Another way to think about an incentive spirometer and the effects of pulmonary rehab. First, we need to talk about patient interviewing. So how do we cultivate these conversations? And what does that look like when we're trying to get more information out of them? So the information gained while patient interviewing, we were interviewing the patient and we're interviewing the family, is extremely valuable. It allows us to form trust, to build that trust, and to get our patients to open up. So I'm going to give you an example. I had a patient in a hospital for 4 days, and they were in with a COPD exacerbation. So that included the shortness of breath, the wheezing, nausea, vomiting, and she actually had to increase liver enzymes. So on day 2, when I started to see her, I was going through the patient interview, building that relationship with her, and by the time I was done seeing her, on the last day that she was there, she finally opened up to me about what she did at home that caused her hospitalization. So through that conversation and building trust, I found out that she was taking Gorilla Glue and she had cracked her tooth. So she took that Gorilla Glue and she thought that she could glue her tooth back on. So ultimately she ingested the Gorilla Glue. And then she divulged later that she had sprayed ant killer in her window to kill a spider. But when she was spraying that spray in the window, it actually blew back into her face. So she had not said anything to the hospitalist or the nurse, but this easily could have explained her loss of appetite, her nausea, her vomiting, her difficulty breathing, and then her increased liver enzymes, because the liver is what filters the body. So as you can see, when we talk to a patient and we perform a patient interview, if it's done correctly, we can find answers that we didn't even know we were looking for. So to start a patient interview process, we must first establish a rapport with the patient. We must be taking into consideration what that patient wants for privacy. So make sure that we're looking to respect the patient's privacy, that we're keeping in mind who's in the patient's room, and then also look at their face. I know before with all those masks, now that we don't have the masks as frequently, recognize facial cues. I think this is kind of funny because we had the masks on for so long, we ourselves make facial cues underneath our masks, and now we have to watch our own facial cues when we're talking with patients. So facial expressions can give clues on things that the patient is not saying. So this even goes with the family as well. But your facial expressions, those are also a great way to connect with the patient, to show the patient support, openness in that conversation. And then be in the patient's field of vision. So sit facing the patient whenever possible. If you are unable to sit in front of the patient, make sure that you have open gestures. Make sure your arms are not crossed. Make sure you're looking at them and that you're not leaning on something. You want to make sure that you're comfortable, and then you make the patient feel comfortable. And try not to loom over the patient. That is super important. That's why I always will sit or I'll kneel whenever I have a conversation with somebody. And then consider how you look. So communication is delivered with the physician's, I'm sorry, with the physical appearance, and not just speech. So sit with that open posture, lean forward, make that eye contact, and relax. And then ask open-ended questions. So try and form questions that will not allow the patient to answer them in yeses or nos. Leave medical terminology out. Super important. I think that we slip in this language without even noticing, but it is very interesting because the average person, the average American, has only an 8th grade reading level. And I mean, that's the average person. So we know that there's an abundance of people who fall below average. And from my experience alone, the clientele that I see, the COPD patients, the asthma patients, that have COPD and who've developed it in the long run, who have congestive heart failure, they do not have an 8th grade reading level. And those are the types of patients that are more susceptible to getting those chronic diseases, are the ones that are probably going to be below that 8th grade reading level. And then listen. So too often we are thinking about the next question. We are thinking about the next step rather than being mindful to what the patient is telling you. This one is really important. As we're going to talk going forward, I'm going to talk about those things that we might not need to say with every single person. So maybe you have a patient who doesn't need NIV therapy, and that wouldn't be appropriate to bring up then. We want to just talk about what's appropriate for that patient. Same thing with smoking cessation. We don't want to talk to a patient about that if they've already quit smoking many years ago. And then culture matters. If you live in an area with different cultures, this is something that you need to know and figure out those social customs, so that way you can build those relationships with the patient and family quicker. Education and health literacy. Nearly 47% of Americans suffer from some chronic disease, and 80% of those have 2 or more chronic illnesses. I found it very interesting that the average doctor's office visit is only 17 minutes, 17.5 minutes, and that makes up for a patient speaking 5.3 of those minutes and the physician speaking 5.2 of those minutes. And now that was an average. There was a couple of studies that said it was around 13 and then some minutes for that doctor's visit, and then some other studies said that it was 21 minutes. So the average being 17.5. But really, that is not enough time to have that clear, concise conversation about what's going on, allowing for the patient's brain to really absorb that information. And not to mention, in 2003, the U.S. Department of Education conducted a national assessment on health literacy and found that 36% had a serious limitation. So when we talk about COPD management, when you go into a room and you're doing, some sort of treatment and your patient asks you questions, really think about, what information can I give them? How can I change this? I know that they probably didn't get this information before. Patients' understanding of a chronic disease in their first year is considerably low, and that is really because of the overwhelming feeling and shock of their diagnosis. If a patient went to a doctor for shortness of breath and found that they have, say, stage 1 COPD, and the PCP probably will just give them their albuterol and tell them to take that for their infrequent shortness of breath. But, to be honest, they probably won't even give them any other information than, here, I'm going to give you an inhaler for your shortness of breath. And then failing to even give the patient, instructions on how to even use their inhaler. So I come from, I was from Wisconsin originally, and at the pharmacy there, my pharmacist that I used to work in a pharmacy, they would make it a specific effort to take the inhaler out of the box and show the patient on how to take it. Now, I had gotten an inhaler for bronchitis a few months ago, and they did not take it out of the box. They did not make any effort to show me how to use it at all. And we're going to get into inhaler technique in a little bit, but I just wanted to give you an example about, what patients are actually getting in the doctor's office. What quality of education are they getting? The average person probably really only gets their education from the television. And there is an abundance of misinformation and disinformation in advertising. So they may think that they're managed with that inhaler, and they can keep doing everything the same. Life doesn't have to change. They can continue to smoke. They can continue to use those toxic chemicals, not protecting their lungs. But if nothing changes, what gave them COPD in the first place? If we don't change anything, won't COPD get worse? If the provider is only solving the symptom, if we're only giving them medication for that symptom right there, then the patient will likely progress. We want to make sure that we're getting to the root cause and really trying to explain things, even little bits of, nuggets of information here and there. One of the very interesting things is that the average person needs to hear something 7 times in order to commit it to memory. So honestly, when I'm done with this presentation, I only expect you guys to remember about 20% of what I said. But this one I think is very important, just that we repeat ourselves over and over. Here are some key things that we can try to talk to our patients about. So what causes COPD? So we know COPD is caused from smoking, obviously, but many patients think that's the only reason why they have COPD. Many do not take into consideration the small irritants that they have every day, or even what they do for a living, or how they grew up as a factor of what contributed to their COPD. This chronic inflammatory lung disease is not only caused by consistent tobacco inhalation, but it's also from the consistent inhalation of these toxic fumes and pollution. So COPD triggers things that we should talk to them about through the patient interview or casual conversation. I can always find out, or I can almost always, I should say, find out how their episode has been triggered. So if you ask a patient, I challenge you guys, when you have a patient and they're in there for COPD, challenge them. Like, what happened before you came in? And that's, again, how I found out the person from the story before she sprayed the ant killer in the window and it blew back in her face. But I have another 2 examples for you. So this one is an example of a gentleman who I met, and he was pretty active at home. He didn't really have any significant limitations or anything. He was a current smoker at half a pack a day. He's been doing that for a long time. But this gentleman was cleaning his bathroom and he dropped bleach in his tub. Now he picked it up immediately, and then he went outside because he didn't like the smell. He did notice that there was a change in his breathing, but it was manageable. He didn't really think anything of it. And the next day he went out weed whacking and he sprayed himself in the face with dirt. And now within hours, he ended up in the hospital. So needless to say, both of these exposures so close together placed him in the hospital for about 5 days. So that was the trigger to COPD. So the next I have is a gentleman who yearly in September, he would get pneumonia. Now, I had just started at this hospital and I looked back at his records and I seen he was in the last 3 years with pneumonia, and he's got COPD and he's got heart failure. And then just through that patient interview, through talking with him, I found out, one, that he's a current everyday smoker, and I think he was at about a pack a day. But he liked to open up his windows in the fall. So again, I used to be from Wisconsin, so the fall is in September, and he would open up his windows to get that cool air in. And he lived in the country, so his neighbors would burn the leaves, and the air pollution and the mold. So he's got the air pollution from the burning leaves, the mold because everything is starting to decay, break down, and this is going to increase his mucus. It's going to cause him to have mucus plugging, increase shortness of breath, and then because he smokes, the mucus can't clear out of his lungs because he's got COPD and heart failure. He doesn't move around as much as he normally would or has in the last couple of years. So this is the perfect storm for getting pneumonia. So for him, I actually recommended that he get one of those air purifying systems in his house, and then unfortunately, not to open up his windows when he sees that his neighbor is going to be burning the leaves. And then honestly, I worked for that hospital for, I think it was 3 years. I had not seen him since then. And I was the only one doing what I did there. So it's really important that we look at why the patient's in the hospital. Just I challenge you guys to talk to that patient to find out like what did actually happen, what kind of triggers. Yes, COPD exacerbations can be triggered from many other things like a virus or something, but think about what are those other things that the patient could have done? What can we help educate? Maybe avoid bleach and Pine Sol and Windex, and don't go outside when it's really hot and humid. So how does air quality affect your health? I want to help everyone just to better understand how air quality affects the health, since aside from smoking, this is really the second largest contributor to COPD flare-ups. So during sunny days, a rise in temperature occurs, and then this increases the concentration of ground level ozone. So ground level ozone is not emitted directly into the air, but is a reaction to the heat and the air pollutants. The air pollutants comes from exhaust and paint fumes and aerosols and manufacturer emissions, and essentially it causes smog and acts like a blanket that traps this harmful air over and into a lower level. So it's not up in the sky like you hear the word ozone layer, but it's down low where we have the cars, the people, the homes, all of that. So this is more prevalent in cities, but with the wind, it definitely does travel and it causes COPD exacerbations. So the ground level ozone is increasing actually the length of allergy season. So that's super interesting, and we are starting to see more people in the ER because of the poor air quality, and because you'll see on the news channels the air quality index. So that is indicative of what the ground level ozone is, and just our surrounding air quality, obviously. But there has been a direct link between high days of poor air quality and COPD and asthma exacerbations. So things that patients can do to improve their ventilation is to improve their ventilation at home, just by using an air filtration system, changing their AC filters regularly, use a vent while cooking can help. Some of the cooking and the gases can be harmful. And then using a dehumidifier can reduce the amount of moisture that's in the air and reduce the risk of inhaled irritants such as mold and mildew. So go outside. Another thing that they can do is go outside in the mornings or in the evenings. So just keep that in mind when you're educating your patients. So oxygen therapy. Oxygen was the first treatment shown to prolong life in COPD. But there was a randomized control study found on 87 patients that used oxygen at 2 liters every night for 15 hours, and this would include hours over the night. So how many times do we have patients that say, I only use my oxygen as needed, or I don't use my oxygen because I feel like I don't need it, or I don't want to use my oxygen, but I know I need it. So this study looked into all of that. It looked into why people should use their oxygen at night. They found that there was an increase of life expectancy by 3 years. And so this study took place over 16 years, and the information obtained concluded that the supplementation of oxygen for those with severe resting hypoxemia had an increased life expectancy and improved mean pulmonary artery pressures. So if a patient says, I only want to use my oxygen when I need it, or I feel like I don't need it, or all those other excuses we get when patients don't have their oxygen in their nose, just, give them that information. Oxygen increases life expectancy at night when you use it every single day. We can't make people use it all the time if they don't want to, but at least use it at night. And then also keep in mind the oxygen saturation. I know as respiratory therapists, we all know that it's so important for COPD patients to have oxygen saturation between 88 and 92, and we have to constantly be educating everybody else on that fact. But here are some reasons why. So decrease, what it does if you have too much oxygen is it decreases the hypoxic drive. So low oxygen drives the patient's need to ventilate, and it decreases the level of CO2 that builds up. If a patient gets too much oxygen, it will undo the natural hypoxic pulmonary vasoconstriction. Okay, let me explain that a little bit. So hypoxic vasoconstriction, if a patient gets too much oxygen, it's going to undo this other natural process called hypoxic pulmonary vasoconstriction. So hypoxic pulmonary vasoconstriction is when you have worsening VQ matching, and it creates hypercarbia because areas of the lung are not well ventilated. So when the parts of the lungs are not well ventilated, it causes vasoconstriction to compensate and reroute the blood to other areas so that they can continue to work properly. So if we give a patient too much oxygen, oxygen is a potent vasodilator, and it will undo that natural intrinsic process if misused. So super important that we keep patients within that range. We don't want them to be, at home and using their oxygen and they're at 99%. We want to make sure that we educate them too, even when they're going home on oxygen. Okay, I know that this. You have oxygen, you're in the hospital right now, you're overcoming this pneumonia or COPD exacerbation, but keep in mind that this is while you are recovering, that they too need to be their own advocate for their oxygen level. And that is exactly why, because of the hypoxic pulmonary vasoconstriction process, we do not want to cause more damage by giving them too much oxygen or them misusing the oxygen at home. So talked a little bit about why it's important for patients to use it when they need it. And then we talked a little bit about why it's important for oxygen saturation to be within that range, including when they go home after a couple of days of being in the hospital. I can't stress that enough. So spacer use and inhaler technique. Why is it important that patients use a spacer with medication? So I've been at a few different hospitals. I moved around to different states, and I find that every hospital is different. So some hospitals will just hand the inhaler to the patient, and some will give them a spacer. So there was a study done on 175 patients with a total of 192 inhalers given, and they found that only 2.86% of those patients actually took their medications correctly. Wow, 2.86%. So during an exacerbation, patients' inspiratory capacity changes, making them unable to fully deposit that medication into the lungs. Well, when a person is feeling short of breath, that's really when they need their medication. That's when they want to get their rescue inhaler. And that's typically why they're overusing it. So when you use a spacer with the inhaler, the patient will get 70% more medication into the lungs. That is huge. I think spacers should be given with every single person who gets an inhaler, because when you're in a COPD exacerbation, or when you need an inhaler, you're short of breath, and they are just not able to pull in that volume to deposit that medication into the lungs. So this tool is just something to assist them. So super important that we're making sure either we're giving them the spacer that they're using in the hospital, if that's allowed, or that you just ask the patient if they can ask their provider for a prescription, or even the hospitalist if they can write a prescription for the patient when they leave. So we know that 98% of patients have incorrect inhaler technique. So that causes the medication to only reach their tongue and their throat we really need to be checking the inhaler technique more often. And the way that we can do that is by using the in-check dial. So an in-check dial is the little device underneath the spacer, and this is going to emulate what a inhaler would be like. So it's going to simulate a DPI or an NBI, and then it's going to make sure, it's going to evaluate the patient's ability to inhale that flow. I tried this, and I tried it on the hand inhaler, and I'm like, I shouldn't even be using a hand inhaler. Not that I do, but I'm just saying, like, I would not be able to fully inhale that because you have to get it at 60, I believe it's 60 liters of flow for 5 whole seconds. Many patients can get it, like once, but they can't hold it there. So this device is something that's going to help to assess the patient's respiratory muscles, their ability to inhale that medication, just to make sure that they're taking it correctly. And if not, maybe we need to switch that hand inhaler to a Respimat or an Ellipta or something along those natures. NIV therapy. An episode of acute respiratory failure represents the progression of COPD and significantly impacts their mortality rate, both initially and within the following 12 months after that episode. So to be more specific, there was a study completed on 150 patients that were treated with traditional therapies. They were just treated with the steroids, the inhalers, following their chronic respiratory failure hospitalization. And out of that, 79.9 were likely to readmit. And then that was within 1 year. And then out of that 79.9, 49.1 of those would die. So those who used NIV AVAPs significantly decreased their mortality risk by 12% and had better quality of life. So again, if you have a patient who says how to identify NIV is needed beyond the hospital, if you have a patient with one of those or two of those or any of those, we need to make sure that we're talking to them. Or is that something that they could ask their pulmonologist? Is that something that we need to figure out for them in the hospital? I know every hospital is different. My hospital, before I was there, they did not do AVAPS therapy for patients. But now that I'm there, I do AVAPS therapy, get that for patients to go home on all the time. It's important to identify when a patient is appropriate to transition to this NIV at home. Many studies have shown the benefits of early use in this AVAPS therapy and the improvement of quality life, sleep, and the reduction of readmissions. I do have a CEU on AVAPS use in COPD, and that really does a deep dive into the statistics. It compares the NIV therapies, looks into the setting, the contraindications, and much more. So I'd highly recommend checking that one out. But here are some highlights on the 3 different types of NIV. So I'm looking at these and I'm comparing them to see which device is more beneficial for our COPD patient. So many patients have something called overlap syndrome. So that's going to be your obstructive sleep apnea and your COPD. So just keep that in mind for a second. So continuous positive airway pressure, what that does is going to splint open the airways and it's going to reduce the airway resistance. However, it does increase dynamic pulmonary hyperinflation, and its effects are more significant in patients with inspiratory muscle weakness. That would be our COPD patient. So what is a great intervention for obstructive sleep apnea is not going to be as beneficial for your COPD patient, and it will actually likely decrease the compliance and fatigue of the diaphragm. So it's going to cause fatigue of the diaphragm. It's going to make the patient not want to wear it because they're constantly have to fight against it and they're going to get worn out. So this would be a great conversation with a patient who does have that overlap syndrome. So that's your COPD and your obstructive sleep apnea. Maybe CPAP was good for them when they had just the OSA alone, and maybe at the beginning stages of COPD. But if your patient's in the hospital and saying, I'm just not using that machine, we might need to upgrade them to AVAPS or have that conversation with them so they can have it with their provider. And then bilevel positive airway pressure, so that's your BiPAP. So that's going to set your inspiratory pressure and your expiratory pressure, and that causes volume to be variable. So asynchrony and intolerance is noted in some patients so it's going to be noted in patients and cause decrease in compliance and effects. If your patient continues to state they cannot tolerate this therapy, then please consider advancing the patient to AVAPs. So BiPAP is a great tool for patients, but when you're thinking of the patient in the respiratory muscles and having that constant pressure going at them and the volumes being variable over AVAPs, BiPAP was something that was not as beneficial as quickly. So in the CEU that I have on AVAPs, we go into a more deep dive into comparing studies, but they did find that when comparing BiPAP and AVAPs therapy used in a hospital, that AVAPs with the advanced stages of COPD was able to decrease the CO2 in patients more rapidly when compared at 1 hour, 6 hours, and 24 hours. And more people said that they liked it a lot better and they were more compliant with it. So obviously compliance is the key to getting patients to not have to be intubated. We want them to keep it on. We want it to work quickly so we don't have to advance our therapies on that. So AVAPs, your average volume assured pressure support, has proven to show greater reduction in that CO2 when compared to BiPAP. Patients using AVAPs at home have increased vitality, confidence, pulmonary function tests. They have increased physical function, they have decreased bodily pain, they have decreased daytime PaCO2, and their 6-minute walk test distance increased. All sorts of good things that come from AVAPs, decreasing anxiety, decrease in atelectasis, decrease in muscle fatigue. So how to identify NIV is needed beyond the hospital. Look over to that little box there, and if you have those, if a patient says that, if you notice that they've been in quite often, that might be an idea to educate the patient about. Airway clearance device. So we know COPD causes increased mucus production, but could your patient have bronchiectasis as well? So COPD and bronchiectasis are similar in symptoms, and bronchiectasis is caused by consistent inflammation and infection in the lung that causes the misshapen of the airways. And so this disease process causes permanent damage to the lungs. It causes the permanent damage, it causes permanent inflammation, and it's going to have the repeat infections. So ultimately, it's going to limit airflow, causing patients to have more wheezing, coughing, shortness of breath, and clearing the lungs on a daily basis would provide great relief to slow the progression. So often, patients might start off having COPD, or they might, I feel like bronchiectasis is something that's going to be underdiagnosed. I had another story about this. So I had a patient, she was in the hospital monthly and with pneumonia and mucus production. She was intubated twice, and finally I was able to see her. I was new at the hospital at this time, and I got her a vest and educated her on, how to, she didn't smoke, she never smoked, but educated her on how to clear the lungs and get the mucus out, and how to avoid those different triggers that we know damage the lungs, even just as much as smoking, like the different chemicals and stuff. So something to think about. There was self-reported data from Respirotech, so that's who this vest is from, specifically on the screen. But it is in 2020, there was 18,000 patients that had bronchiectasis, and over 2 years, they gathered this data. 62% decreased in yearly hospitalizations, 63% increased in the ability to clear the lungs, and 13% decreased in antibiotic use, and there was a 45% increase in respiratory health. So how to identify a patient needs to have CPT at home? Ask yourself these questions. Does the patient have frequent pneumonia? Are they using any other sort of OPEP device or a way of clearing the lungs? Is it not helping? Is there still trouble getting the mucus out? And could your patient have bronchiectasis? And that's usually tested with a CT. So talking about pulmonary rehab. So I would be very curious to see how many talk to their patients about pulmonary rehab. I know that when I was in school for respiratory, they did not teach us too much about pulmonary rehab. I think it's something that people should float through as part of their like schooling and everything, so we can see what that looks like. But I'd be curious to see how many people talk to their patients about pulmonary rehab, and to see what stories you guys have on how it's impacted people's lives. So maybe at the end we could talk about that. Pulmonary rehab is a great way to offer patients a community to increase their physical ability. I like to say it helps people kind of figure out what they're capable of. Often people don't see what they've lost until it's too far gone. So teaching our patients that COPD is not just, here you go, take this medication, but it's a lifestyle change. And pulmonary rehab helps to retrain people to figure out what are they capable of? How can I work with my COPD and not against it? So I'm going to give you an example here. See the words sit to stand. So this is something that is very basic, and maybe most of you know it, but so when we do something that's difficult, we tend to hold our breath. So when we go from sitting to standing, if that's hard for us, we will hold our breath. If I go to reach for my remote that I dropped on the floor, I will hold my breath and I will pick it up. So what this does is this helps a patient to be able to learn how to breathe through it. So when they sit on a chair, what I want people to do is to take a nice cleansing breath first. They take a big breath through their nose, they fill up their lungs, and then when they go up, when they exert themselves, they are going to exhale on that movement. And then when they go from standing to sit back down, they're going to inhale. So exhale with that upward movement, with that exertion, and then exhale on that downward movement. So it's making them not hold their breath. It's causing them to figure out a new way to breathe that right now they have to practice, but eventually it'll just become something that's natural. So again, COPD education is all about empowering the patient and giving them the tools and devices they need to assist their body. So I'm basically telling everybody, okay, go against how you've been breathing your whole life, how we do it instinctually, and now we have to figure out how can we work with our COPD and how can we rearrange our breathing. So that's just one of the examples of pulmonary rehab. Optimal benefits are typically seen within 6 to 8 weeks. And that's with using it twice daily. Insurance has guidelines on it, and it depends on what the insurance coverage is, but it's typically 72 sessions per lifetime. And then that can typically be broken up, or people can do it all together, depending on what patients prefer. So how many times have we gotten out incentive spirometers? How many times have we given them out? Too many to count, I'm sure. I have been in many hospitals in that nursing provided them, respiratory provided them, but they remained either unopened at the side of the bed, or the patient just said they just handed it to me and they walked out the room. So when we're educating patients on this, we really need to discuss with them what the incentive spirometer does for them while they're in the hospital, but also we can explain to them that this can be used as a device to visually look at every day in the morning and at night to see how much air they're able to fit into their lungs. If you see the picture of the chronic bronchiectasis picture, you see the bronchiole that's nice and open, you see the one that's tight and full of mucus. I like to explain to the patient, okay, you do this every morning, you do the incentive spirometer every morning, and you do it every night. And then if you have good lungs, if your lungs are open and nice and relaxed, you're going to be able to fit more air into the lungs. Now, if the lungs are tight and full of mucus, and they've got inflammation, you're going to see that you're not going to be able to fit as much air into those lungs as you would if they were nice and open. The evidence shows that the utilization of an IS on COPD patients, both hospitalized and part of a long-term treatment plan, can be very beneficial. There was a study that seen improvement in ABGs, so the PaCO2 and the PaO2 results, spirometry tests with the FEV1 and FVC, and then the peak expiratory flow rates, and improvement in their diaphragm function and the thickness ratio. So there was no evidence that it affected the FVC in the spirometry testing. And then there was no difference in the dyspnea scale, so the MMRC. However, it did increase the function of the diaphragm, along with the improvement of the mucus plugging, the air movement, the atelectasis. All of those are going to, in turn, help the dyspnea scale. So that was kind of surprising that it said that they didn't find any difference in that. But encourage your patients to use the Incentive Spirometer, not only while they're in the hospital, but take this with you and use it every single day until the end of time, in the morning, at night, because it's going to overall increase their ABG results. It's going to increase or improve their spirometry results and their peak expiratory flow rates. The Incentive Spirometer is used to maximally inflate the lungs and hold on to that inflation. It encourages the patients with that visual feedback. So again, we want to make sure that the patients are using it every day and every night. We want to improve the atelectasis, and we want them to see that it's a visual indicator that, hey, maybe I do have an inflammatory process going on. Maybe I had a trigger happening. Maybe I need to start looking at taking more of my medication when I have shortness of breath. And looking at the COPD action plan, which I'll get into in just a few minutes. So smoking cessation, quitting smoking obviously is going to remain the #1 intervention for the progression of COPD. And what's interesting is that most people who smoke will tell you, I have tried and I just can't quit. And here are just some interesting information that you can take back to your patient who says that they've tried everything. So addiction is only 20% the physical withdrawal and cravings, but it's actually largely 80% made up of the relationship people have with smoking and feelings. So people who use nicotine replacement therapy and counseling are going to be widely more successful in quitting. The average person tries and fails 9 times before being successful. So tell them to not lose hope, that it is something that everybody, I wouldn't say everybody, but something that a lot of people fail at, and then they get it eventually. So keep trying, see what works. Using an e-cigarette is not the answer. Yes, there are fewer chemicals in the vape products, a carrier oil, the nicotine product, and some flavoring, but that is going to be something that has a whole list of side effects going down the road eventually. So please do not recommend that your patients use e-cigarettes as a nicotine replacement therapy. So I have my national certification for nicotine tobacco treatment. And one of the things that you'll hear patients say is that I can't smoke and use my patches at the same time. So what we have found out, what the FDA now supports, is that patients can use nicotine replacement therapy patches and smoke, and they actually recommend that people start using the patches while they're smoking, because patients are going to self-titrate down because they're getting that level of nicotine in the patch, and so they are going to start smoking less when they use that. But it does say on the package not to use it. So I just find that kind of interesting. The FDA does support that they can use it, but on the package, it still has old information saying do not smoke with this. And so many patients who are not ready to quit smoking, maybe it would be beneficial if we say, okay, go ahead and you're going to start taking that nicotine replacement patch, and then you're going to start to wean down, and this will be something to help them get started, rather than patients are just so afraid of putting that down right away that they just refuse to entertain any sort of nicotine replacement therapy because they're afraid of just what the withdrawals would look like. One of the other things I'm going to say is that the crucial period for the withdrawal symptoms is about 2 to 3 weeks, and then the psychological is about 3 to 12 months is the critical period, but really that one can go on for a long time. I do have nicotine dependence and the truth behind vaping, and that one is on the 28th of this month. If anyone is interested in looking more into why vaping is not the answer to quitting smoking. And then nutrition in COPD, it often gets overlooked. Patients who have COPD, it's really important to look at what causes the chronic systemic inflammation. And there's different tips that we can offer the patient to help reduce the inflammation in the body, as well as help with increasing their exercise capacity, to help with their energy, and to help negate pulmonary cachexia, which is when they have fat loss with their mass. And then patients who have COPD often have an increased nutritional needs. So some of the things that we need to look at is the tips for nutrition, making sure that they have high protein foods. It's essential for maintaining muscle mass. And so this would be more like your nut butters, your beans, your peas, canned tuna. The next way that we can increase patients' energy is through fat. So this comes from plants or animals, but fats produce less CO2 waste when digested and is a better source of energy over carbohydrates. So that would be your avocados, your olives, your healthy fat oils. And then carbohydrates are the third way that we can introduce more energy into a patient. And so these would be to avoid diets high in carbs with like sugar starches, but we want to focus more on the complex carbs. So that would be like your whole wheat and your whole grain and your potatoes and all of that. But when patients have too much carbohydrates, it can be something that just kind of tips them over into a COPD exacerbation, because when they eat so much carbs, it's going to expand in their stomach. It's going to cause that increase of CO2 retention. Palliative care is a specialized medical care given to people with serious illnesses. So keep in mind, we can be offering palliative care services to anybody, any age or any stage of a chronic illness. Frequently asked questions that I get all the time is, how do I know if palliative care is right for me? So palliative care can be right for a patient with any sort of serious illness. And what they are going to do is just have a team to help work through the patient's symptoms, understand what their diagnosis is, how to help them with their treatment goals and their options, and how to give support to their family, make sure that the patients have either like a MOST form or some sort of like 5 wishes or like living will, something like that. So palliative care not only helps the patient with the symptom management, but just making sure people feel that they're getting everything that they need from the support, the mental support side. Now let's talk about hospice. How and when to speak to attending a physician, patient, and family when patients are readmitted due to their disease and they continue to avoid hospice. We can always be evaluating to have the patient's best interests. So starting the conversation and making these recommendations. When a doctor estimates a patient has less than 6 months to live, the patient can enroll into Medicare hospice benefits, and all of the patient's medications, necessary services, and equipment, and all of that is going to be covered for the patient at no cost through Medicare or through private insurance. The different hospice criteria include when the FEV1 is lower than 30, the PaCO2 is greater than 50, oral steroid dependent, dyspnea at rest. There's a lot of different reasons that a patient could enroll into hospice. So looking at the COPD action plans, this comes from the American Lung Association, and I'm a huge advocate for it. Teaching self-management is extremely important. What is a person going to do if they start to feel these signs and symptoms? Printing these off, giving it to the patient is the best thing that I could have ever done for this hospital. When we look at what the signs and symptoms are, every single action that the patient is going to do or what the person feels and they know when they need to start taking action is going to be different. So having and encouraging the patient to look at what their action is, working that out with the doctor. How often should I use my inhaler? Should I have the conversation with them about steroids? Maybe they get frequent pneumonia and something always happens on a Friday after 5 o'clock. So how can I start my antibiotic use if you're not open? When should I be using my oxygen if they have it at home and maybe they're just taking it as needed? So making sure that they know, especially to be using it at night. And then of course, when should they be talking to their doctor? When would that be an appropriate time? So this COPD action plan, if you do not use it in your hospital, I would highly recommend seeing if that's something that you can give out to your patients. Not only allows you to go over the signs and symptoms, but helps them to create an action plan and build that conversation with the doctor. So the takeaways here: the average person needs to hear something 7 times in order to commit it to memory. 98% do not take their inhalers correctly. Using a spacer with an inhaler will increase the deposition by 70%. AVAPS therapy specifically can decrease the mortality risk to 12% in someone who has had chronic respiratory failure, and it will increase their quality of life. The standardizing of an incentive spirometer use in COPD patients can improve the PaCO2, respiratory function, the blood gases altogether, and the diaphragmatic function. The average person fails 9 times at quitting smoking. So never stop trying. Even if you've seen the person, a week ago, never stop trying to ask if they're ready to quit or how you can get them to quit. And then smoking while using nicotine replacement therapy is now supported by the FDA. A person will self-titrate nicotine to reach what they need to avoid withdrawal symptoms. And pulmonary rehab has been shown to be most effective therapeutic strategy to improve shortness of breath, health status, and exercise tolerance. And then the optimal benefit is seen within 6 to 8 weeks. And COPD education is all about empowering the patient and giving them the tool and the devices so they can be successful.